Isn't that awesome? There's a bell. But I mean, can you get any more better than that? I'm super excited. Good morning and welcome to Grand Rounds. I'm so excited to see so many of you. Can everybody hear me okay? All right, we're gonna get started today. We've got a bunch of great speakers. I'm Dr. Cook. I'm a co-chair on transfusion with Dr. Soto, our pathologist. He's gonna be part of our panel discussion today. We've got three speakers for you. We've got Dr. Hines, third year internal medicine on transfusion, that's going to be talking today. We've got Dr. Garland. He's a fifth year surgery resident who's on transfusion as well. And then we've got Dr. Reich Martins. Did I do it right?
That's correct.
Okay, and he's one of our second year ER resident, and he's going to be speaking as well. Super excited to have everybody here. I'm supposed to mention the code. The code is 2939. The code is 2939. Everybody get that?
You go.
Okay. All right. Well, let's not Yakami, the lab manager, should be here in a little bit. So I want to go ahead and introduce her because she'll be part of the panel discussion too as well. And let's get started, not waste any time.
Hello. Can you all hear me okay? Can you hear me on Zoom?
Yes, we can. Thank you.
Would be a good lecture if we didn't have, a little ink right there. All right.
Good morning, everyone. I'm Seraphim. I'm one of the internal medicine PGY2s, and I'm going to talk to you about transfusion practices. So just a brief overview of what we're going to be talking about today. We'll talk about the clinical practice guidelines of each and every blood product, which are labeled up there. And then we'll also talk about the Choosing Wisely campaign and, proven transfusion practices. So getting started, we'll talk about PRVCs first. A single unit of PRVCs holds approximately 300 to 350 mils of total volume, 250 milligrams of iron, and 200 mils of RBC specifically. We look at RBCs when we're talking about anemia, just in terms of the thresholds for anemia. In males, we remember a hemoglobin of less than 13, in females, a hemoglobin of less than 12. When we're transfusing these packed red blood cells, we want to remember our restricted threshold approach to transfusion. We look for a threshold of less than 7 for transfusion asymptomatic patients and critically ill patients, and then less than 8 in patients in CAD or those patients undergoing orthopedic surgery. It's important not to perform serial rechecks of hemoglobin on clinically stable patients, as this can lead us to undergo unnecessary transfusion. Some pros to remember with PRVCs: you always want to remember the cause of anemia before you're transfusing, whether it's acute blood loss anemia or iron deficiency anemia, because there's different ways to manage each one. You want to view every transfusion as a transplant. You want to, make sure that you are giving them to the transplant to who needs it, because each blood unit comes with inherent risk, whether it be a transfusion reaction or something else. We always want to make sure we're typing screening our patients before we give them blood, again, to avoid those transfusion reactions. And then always transfuse 1 unit of PRVCs at a time, unless your patient's actively bleeding. There are other ways to also optimize perfusion other than giving blood, and we can remember those by optimizing hemodynamic support, optimizing patient's temperature, oxygenation, and acid-base balances. You can also correct underlying deficiencies with iron, B12, folate, and even EPO when indicated. And then you always want to remember, you don't want to transfuse blood cells in somebody who's iron deficient. Again, there's better ways to help them with their low hemoglobins other than blood. So here's a lovely diagram just to drive the theme home. If you learned well with algorithms, it kind of just goes over what you need to do when you have a patient that's coming in with anemia. You want to look at their hemoglobin levels, and then it also highlights those transfusion thresholds that we talked about earlier. Always want to remember that less than 7 in acutely ill or just hemodynamically stable patients, and then the less than 8 threshold is important for our patients with CAD. Now on to platelets. So as a general rule of thumb, a single unit of platelets should raise your platelet count by 50 to 60 platelets per MCL. When we are transfusing platelets, it's in a single unit equivalent. It's important that we pay attention to our platelet counts and know that the count should rise between 10 minutes to 1 hour following transfusion, and then gradually decline over 72 hours as the platelets are processed in the body. These guys have to be stored at room temperature. Their shelf life is 5 days. Because of that room temperature storage, because we wouldn't want any bacteria growth to happen with these units. The biggest thing I think to remember that's important when it comes to the indication for transfusion of platelets is just we want to transfuse when the count is less than 10 to reduce the risk of spontaneous bleeding. In terms of other indications for platelets, it really depends on the clinical scenario at hand. Again, you want to ask, is the patient bleeding or not? Is it life-threatening bleeding? You want to ask if they're undergoing a specific procedure, some of which are here listed on this slide, with their different procedural thresholds. Procedures include LPs, bronchs, central lines placements, bone marrow biopsies, and then neurosurgery as well. In terms of when we're thinking about a patient who's actively bleeding, those who have severe bleeding, including patients in the IC, you want to transfuse at a threshold of less than 50,000. When bleeding is not life-threatening, we can transfuse at the threshold of less than 30,000. That threshold does go down because of the not life-threatening issue at hand. And then in patients who have intracranial bleeding or are, in a trauma situation, the threshold actually increased to 100,000. So those are kind of the big things to remember. Also, platelet transfusions are indicated in patients who have inherited or acquired platelet disorders, but you want to make sure their bleeding status before you transfuse platelets. When not to transfuse, the big situations that we want to remember are TTP and HIT, more so with TTP because of the risk of thrombosis. And HIT, more studies are coming out that it's, you can transfuse platelets. However, you want to make sure it's either before or after the procedure, and then again, pay attention to the bleeding status of the patient. Next, we'll talk about fresh frozen plasma, or FFP. So 1 unit of FFP is 200 to 300 mils of volume. FFP is basically your blood without the white blood cells or red blood cells. It's frozen shortly after donation. It specifically includes fibrinogen, albumin, protein C, protein S, antithrombin, tissue factor pathway inhibitor, all those things that help us with our coagulation pathway. A standard dose of FFP can raise your factor levels by 20 to 30%. And these units have to be used within 24 hours of thawing. And so it's important to make sure we use it within those thresholds. In terms of specific indications for FFP, FFP is used generally to correct coagulation factor deficiencies and to prevent coagulopathy. Specific guidelines support its use in massive transfusions, DIC, emergency warfarin reversal without access to PTG concentrate, and then in situations of plasma exchange for conditions like next, we have cryo, which comes from FFP. Cryo specifically made up of hydrogen, factor 8, factor 13, and bottom milligram factor. 1 unit is 10 to 20 mils of volume, and a unit of cryo can raise your hydrogen levels up to about 50 mg per deciliter. And then it's important to remember when you're transfusing and ordering cryo, it will come up in pools of 10 units. So that's not abnormal when you go to order that. Cryo itself is indicated in levels of low fibrinogen or and so you want to look at different thresholds. Your fibrinogen level is 100 to 150. When you start thinking about cryo, I've seen our chemo docs recommended below 150 threshold. It's indicated in situations like DIC, uremia refractory to BDAVP, and then just your acquired deficiencies, or that includes surgery, liver failure, liver transplant, trauma, and acute hemorrhage. So why is this all important? The transfusion community is a big proponent of optimizing our transfusion practices here at OSU. And this is a graph from OBI, which shows our transfusion use of red blood cells specifically compared to other places in our region. So we're number 47. We can see our transfusion use of RBCs is pretty much in the mid tier there. From 2023 to 2024, we have increased our use of blood cells, whether it be warranted or not. So that's something we want to pay attention to when we're transfusing and making sure that we are prudently transfusing. Kind of another perspective when you look at use is amount of units wasted. So this is the graph of the overall units of blood products wasted from 2021 to 2024. In 2020 and 2021, we introduced an education, an education scenario where we had everybody learning more about our proper transfusion needs. And we saw an initial decrease in our use of wastage of blood products. And so we can see a little bit of an increase over time from 2021 to 2024 after that campaign was launched. And so this kind of drives home the fact of why we need to remember these proper transfusion practices that we talked about earlier and make sure we're transfusing when indicated when it comes to all the blood products that we have. Because they're not an infinite supply. So 5 things physicians should question prior to transfusing blood products. This is part of the Choosing Wisely campaign. The Choosing Wisely campaign is an effort to support and engage physicians to be better stewards of finite healthcare resources. Specifically, in this part of it, we're talking about our blood products. So a couple of things to remember here. So don't transfuse more units of RBCs or other components than absolutely necessary. We always want to avoid overtransfusion. It's crucial to minimize the risk associated with blood transfusions, and that's why we adopt those restricted thresholds of transfusion, typically between a hemoglobin of 7 and 8. We always want to consider the patient's symptoms and hemoglobin levels before making a decision. Next, we don't want to transfuse red blood cells for iron deficiency without hemodynamic stability. That's again where we kind of talked about, we want to adopt other practices to help iron deficiency, whether it's oral or IV iron supplementation. This approach versus transfusing a patient is cost effective and also safer for the patient. Third, we don't want to routinely use blood products to reverse warfarin toxicity. So patients requiring reversal of warfarin can often be reversed by vitamin K or discontinuation of warfarin alone. Then we have some of the thresholds there for INR. Fourth, we don't want to report material blood counts on clinically stable patients. To optimize our transfusion decisions, it's important to base them on the first laboratory value of the day for clinically stable patients. And then repeat blood draws can lead to excessive phlebotomy, which can lead to unnecessary transfusions. So just use the first 5 of the day. It'll get you where you need to go. And then lastly here, you don't want to transfuse O negative blood except to O negative patients and in emergencies for women of childbearing potential with unknown blood group. So O negative blood is often in short supply. So we need to use it judiciously, whether it's to patients who are actually O negative type, or for women who are unknown, and need blood emergently, while childbearing. And then here's just some places to donate if you're able. You never know, your blood can save people's lives. So if you can, please go ahead and donate. And I will turn it over to Dr. Carlin.
Good morning, y'all. I'm Kenny Garland. I'm one of the 5th-year general surgery residents, and I'm going to be talking about massive transfusion protocol. So we'll go ahead and get into it. So we're going to talk a little bit about why massive transfusion protocol by discussing damage control resuscitation first, talking about the ABC score, which kind of prompted use of all the MTP, and then the proper trial, which was a very big deal in the setting of MTP, and then our current MTP protocols, and then our workflow / our jobs for each nurse and person available during an MTP. So the problem initially, so an estimated 20 to 40% of deaths occurring in the hospitalized trauma patients are secondary to a coagulopathy. Transfusion must be performed quickly and efficiently to reverse this coagulopathy caused by trauma and hemorrhage. Significant pre-planning, coordination between the blood bank, OR, ER, and delivery personnel should be in place to facilitate proper distribution of blood product, or blood and product. Then MTP should be in place at any given facility to kind of help with this. So damage control resuscitation. Early 2000s, the goal of shock resuscitation was largely focused on supporting adequate blood pressure and urine output, and to reverse the metabolic derangement seen in ischemia-associated blood loss. The problem with this was that it didn't kind of focus on the problem at hand, and there were never any long-standing studies that showed that this was of true benefit to a trauma patient. In 2007, Holcomb et al. Submitted that the focus of resuscitation should be shifted to the correction of the coagulopathy of trauma, as well as identifying patients with the lethal triad upon admission. So the lethal triad of trauma is coagulopathy, acidosis, and hypothermia, which continuously go in a circle if not corrected. So damage control resuscitation is currently defined as structured intervention beginning immediately after rapid initial assessment in the ED through the OR or ICU courses. Efforts are directed toward the goal by repeated point of care testing and the use of multiple blood products and adjuncts readily available. Damage control resuscitation in practice is that resuscitation is limited to keep SVP at 90 millimeters of mercury, preventing renewed bleeding from recently clotted vessels, aka keeping them not hypertensive or preventing them from being hypertensive and adding blood loss to that area. And then intravascular volume restoration using thawed plasma or blood in a 1:1 and 1:2 ratio with PRBCs. So the ABC score was created for trauma. The goal was to validate the use of MTP by just early assessment of a patient. And the study showed that in a cohort of all level 1 adult traumas, patients transported directly from the scene, that any ABC score greater than 2 had a 75% sensitivity that the patient would need MTP, while it was 86% specific for predicting need for MTP. It's a pretty simple score. including what you see to the right. So penetrating mechanism, yes or no, systolic blood pressure less than 90, heart rate greater than 120, and a positive fast. That along with physician gestalt is another kind of way to look through this, but this kind of predicted early use of MTP. So the proper trial, so the pragmatic randomized optimal platelet and plasma ratios trial, it was a randomized 2-group phase 3 trial conducted in subjects requiring the highest level of trauma activation and predicted to receive MTP as defined by the ABC score of greater than 2 or physician gestalt with an ABC of less than 2. So the groups in this study were a 1-to-1-to-1 ratio, meaning 1 packed red blood cell, 1 plasma, 1 platelet versus 1-to-1-to-2. There were 25 major trauma centers and 12 of them met the criteria, and there was approximately 680 patients in this study. The 2 primary endpoints were survival within 24 days and then 30 days after admission. Overall, there was no difference in mortality in general for the 24 hours to the 30 days with the 1-to-1-to-1 versus the 1-to-1-to-2. However, the big portion was the 1-to-1-to-1 group achieved hemostasis earlier and experienced less deaths secondary to hemorrhage within that 24 hours. And so this is why this became more prudent to perform this 1-to-1-to-1 ratio. So what is a massive transfusion protocol, which we've kind of touched on already? MTP describes the process of management of blood transfusion requirements in major bleeding episodes, ensuring appropriate use of blood products. It's designed to help decrease deleterious effects of trauma and hemorrhage with the goal of reversing coagulopathy of trauma. And the key is to without wasting product. Places an emphasis on controlling the bleeding, decreasing crystalloid administration early, and administering blood in a ratio of balanced components. It's usually in a 6-to-6-to-1 apheresis units of platelets at most facilities. I believe at OSU, and we just verified with Dr. Cook that it's 4 packed red blood cells, 4 of FFP, and 1 of platelets. And that 1 of platelets is equivalent to kind of those 4. It's vital that all involved in the service lines work together to ensure this method of resuscitation is prioritized as MTP is noted to improve outcomes in both morbidity and mortality. So development of a massive transfusion protocol at OSU. Massive transfusion protocol is a written document that we have that's readily available for all the hospital staff and employees. It's been developed by a multidisciplinary team, as you see here, based on current practice guidelines for damage control resuscitation. So the triggers are, the MTP addresses the triggers, the resuscitation, the clinical setting, the transfusion targets, the use of adjuncts in these patients, and then termination of the MTP. So triggers of initiation of MTP, it's set into motion when massive blood transfusion is necessary, including but not limited to any of the following. So the keys are need for 10 units or more within a 24-hour period, transfusion of greater than 4 units within 1 hour, and the anticipation for more needed within that hour. Greater than 1,500 cc's blood loss documented, which going off of Dr. Heim's PowerPoint, if you saw blood transfusions are approximately 250 or 300 to 330 cc's or so. And so that's about 5 packed red blood cells lost in a patient, which kind of makes sense that you need to give them blood. And then massive GI hemorrhage and ruptured aortic aneurysms are the others. So blood products at OSU. So efficient blood product utilization is a key component of MTP. So packed red blood cells stored for a maximum of 6 weeks. Concern for complication increases with the increased storage time. Plasma should be stored or thawed or liquid, never frozen, so it's readily available in the setting of an MTP. I believe in our boxes it's liquid, correct? Or
The first box.
first box of liquid. An ideal is AB, limited supply. A with low anti-B titers is the next appropriate, and then you switch as soon as the patient's been typed and screened. Then platelets should be stored in enough quantity to have a 1-to-1-to-1 ratio, as we have that 4 to 4 to 1 in our boxes. Is not to be placed in the coolers, it's sent separately. And at the completion of MTP, remaining products should be returned to the blood bank. So MTP, OSU in the clinical setting, universally compatible blood products should be readily available upon arrival. So usually there's some product in the ER. Again, the blood bank is quick to turn over that if necessary. Patients should have a baseline point of care labs drawn on arrival, so PT-INR, fibrinogen, hemogram, ionized calcium, and ABG. It allows for the corrections of those factors of the lethal triad contributing to the coagulopathy. You can also get a TEG or a ROTEM to allow for directed goal therapy of like R values, MA values, etc. Maximum effectiveness achieved in these patients is usually utilizing a rapid transfusion warmer. Transfusion should be should restore perfusion, but allow for permissive hypotension, as we discussed before, with a goal systolic of 90 millimeters of mercury, and then the ratio to be 1 to 1 to 1, which I know sometimes we get away from. And so that's one thing to keep in mind, that those products are in that box for a reason, to keep that ratio pertinent for us and help that patient in a better manner. And then transporting the patient, making sure that the blood bank and the transfusion services know where the patient's going to be is a big deal. So that way the next set of blood product can get to where it needs to go. So finally, the endpoint of trauma or MTP is the decision to seize MTP is made by the surgeon or the interventionalist, basically saying that within the OR or within IR, et cetera, that the bleeding has stopped. And then you also need to meet this other criteria of improved vitals. So improved heart rate, improved blood pressure, improved urine output. So clinically seeing that the patient has improved after this hemostasis has been achieved. It can also be decided by the intensivist by point of care laboratory values and guiding resuscitation from there. So normally these patients will end up in the ICU. And so once we get repeat labs, if the intensivist decides that we are done with MTP, they can cancel it at that time and transfuse as appropriate per their current point of care labs. Lab values to cease transfusion is hemoglobin greater than 10, PT of less than 18, PTT of less than 35, platelet count of greater than 150, and fibrinogen level of greater than 180. And then futile efforts, of course, should end MTP. Some adjuncts to massive transfusion, one is TXA. It inhibits plasminogen activation and plasmid activity, thus stabilizing clots. It was found to be beneficial in the CRASH-2 trial if it was administered within the first 3 hours of a patient having a massive trauma with hemorrhage. And it's effective in surgical settings and trauma and can be used empirically or in response to increased fibrinolytic activity on point of care testing. After the 3 hours has passed, so if you see a patient 4 to 5 hours after a trauma, it has shown no benefit for the patient to give them TXA. So recombinant factor 7A, studied in the setting of warfarin-induced anticoagulation, appears to decrease the transfusion requirements, but no long-term data is available for it. And then PCC, so factors 2, 9, 10, 2, 7, 9, and 10 as well. Urgent reversal of warfarin. It's used in Europe for trauma. It's recommended by the American College of Chest Surgeons in place of FFP for warfarin reversal. And then pediatric considerations, you should continue with the same ratio as 1 to 1 to 1, but decreased in volume to decrease circulatory overload in these patients. So it's 1 unit of packed red cells, 1 unit of FFP, 45 milliliters of platelets. For less than 20 kilograms, they should not receive warmed or not receive rapid infusion, but just use a warm line. And then monitoring MTP, once you set up a protocol like this, you have to monitor like how patients are doing or what indications or different indicators of performance you have. And so some monitoring is the complications that are associated. So non-hemolytic reactions, allergies, respiratory complications, hemolytic reactions, transmission of disease, and death associated with MTP. And then important performance indicators otherwise are time from calling MTP to infusion of the first packed red blood cell, time from calling MTP to infusion of the first unit of plasma, ratio adherence to that 1 to 1 to 1 ratio, informing transfusion service of MTP termination within 1 hour of termination, and the amount of wastage that you have at the end of the MTP. And finally, one of the more important topics is the MTP roles here at OSU. So we have different roles for different groups. And so the first is the communicator. They ensure that blood bank has been notified and MTP has been called to the number 5,000 on an ASCOM. They verify orders are placed, ensure the Belmont is at bedside, which is the rapid transfuser. They ensure all roles have been assigned. They do the MTP progress communication to stay in contact with the physician in the room and verify continuation or discontinuation of MTP. The complete handoff with receiving unit if patient transfers, and then crowd control, so keeping patient or people out of the room that don't need to be present in that room. Then moving on to the documenter, they ensure orders are in place, they document vital signs, they enter orders for labs or other items needed for point of care testing, review lab results that may be needed, and then enter dot phrase once it's like created, which we're working on a dot phrase for MTP at this time. The primary rapid infuser nurse receives blood product from the runner, keeps transfusion sheets, and the secondary nurse, which we'll talk about in a second, basically checks off that blood before applying it to the rapid transfuser. Oops. And then the runner kind of sounds like what it is. They basically grab a ASCOM available and they grab the patient stickers to allow them to run back and forth between blood bank to get the next set of packed red blood cells or FFP or available product when necessary. They wait at the bedside until told, hey, we need to go, or this is available now. And they repeat until the patient transfers to a different area or until MTP is completed. And then the task person, they ensure large bore IVs are available, take vital signs, obtain extra supplies if necessary, and help assist with any other needs of the patient. And then I think this was a very important asterisk to have, is that the patient's primary nurse, so the nurse that has been taking care of that patient, has no specified role. They are to continue taking care of the patient in whatever manner that they have. And so these roles have to be assigned to others available. Okay. So in summary, MTP can decrease mortality in acute settings of blood loss. A documented and easily accessible MTP at OSU has been established and coordinated by a multidisciplinary group. Universal products should be readily available at all times and given in a one-to-one fashion once MTP is activated to reverse coagulopathy. De-escalate from MTP to goal-directed therapy once patient is stabilized. Source control is a key component to discontinuation of MTP, and then review of indicators should occur at specific time intervals to further improve protocols. Right, and that's all I have.
So. All right, my name is Victor. I'm a second year ER resident, and today we're going to be talking about the appropriate use of the uncross-matched blood, which is probably the most frequent use that we have in the hospital, is probably in the ER, since a lot of these times we don't have time to cross-match and type these patients if it's a time constraint, which we'll talk about a little bit later. Some of the objectives of this lecture is differentiate between cross-match and uncross-matched blood, the types of uncross-matched blood, the risks associated with using this uncross-matched blood, when to use this uncross-matched blood, and then the types of non-ABO antigens we frequently think of cross-matching or as hemolytic reactions mainly associated with like typing errors and things like that with ABO, but there's also non-ABO antigens that can cause this. And then how to use this uncross-matched blood, of course. So first, cross-match versus uncross-match. Cross-match, as we know, it's going through the process of ABO and RH typing. Then they do the antibody screening, or they do the antibody screening, the compatibility tests. And then you can select the compatible units for transfusion for the patient. So the type is the ABO-RH testing. The patient's blood cells are mixed with serum that is known to have the antibodies against A and against B to determine the blood type. And then the patient's blood cells are also treated with anti-D antibodies to determine their RH status, which we'll discuss a little bit later because it's pretty important. And then antibody screening, they detect the presence of the most common antibodies in the patient's serum. Essentially, the patient's serum is mixed with red cells with known antigenic composition. So, and then lastly, we get cross-matching, which takes the patient's blood that has been typed and screened already, and you mix it with the compatible donor blood. And if agglutination occurs, it tells you there is other unknown antigens, like the non-ABO antigens, which hasn't been identified originally with the initial screen. So there has to be a little bit more testing done depending on the antigen. So types of uncross-matched blood. Uncross-matched blood can be all the blood types. If the patient type is known, there's certain ways that you can verify it, like electronically, which is not recommended because there could be errors, of course. But if the blood type is unknown, then O blood is transfused instead. It changes based on the gender and age of the patient, which we'll discuss as well in just a little bit. Which there's just a rule about it. So uncross-matched blood usually can be dispensed within 10 minutes, which is why we use it pretty frequently in the ER. But the cross-matching at OSU, I'd say, from my understanding, is just about like 45 minutes. Is that about right? 30 to 45? Yeah, for cross-matching. Yeah, okay. So there's that time constraint, so which is what we're talking about. When there's a time constraint, when there's no time to wait in cross-matching, when there's a hemodynamically unstable patient or a patient that's actively hemorrhaging that you need to have the blood transfused relatively quickly, then we don't have time necessarily to sit and cross-match. But just because there's somebody that's hemodynamically unstable, it's not the same as activating MTP, which was discussed by Dr. Garland. There's certain criteria and certain scenarios that you wouldn't, but it's good to keep in mind that just because somebody's hemodynamically unstable doesn't mean you have to activate MTP. So risks of uncross-matched blood. So there are extravascular hemolytic reactions that are rarely life-threatening. And there's potential sensitization of anti-Ro antibodies for future pregnancies, which we will discuss. And then more importantly, it's kind of interesting. There was a 2015 meta-analysis that showed that the total risk of hemolysis with uncross-matched transfusion was 0.1% risk. So pretty low risk overall, but it's still pretty important to keep in mind that these can happen. And as I mentioned already, there's non-ABO antibodies that can occur. Some of them like antigens like D, E, Kel, and Duffy can be found in uncross-matching units, and they can cause significant harm to the patient. So some of these non-ABO antigens can include like the Lewis system, which is antibodies are usually insignificant, so they rarely cause hemolytic reactions. The I system, they're pretty common cold reacting IgM, but they're usually also insignificant. And then the P system, there's an IgM cold reacting, typically insignificant, but there's a rare form of it that is anti-P1 that can be reactive at the AHG, which can be potentially significant. So the RH system, it's a pretty important one. There's 5 major antigens, D, C, E, and we got lowercase c and e. These are warm reacting IgGs, which is the most common with like these extravascular hemolytic reactions. Out of those 5 antigens, the D is the one that induces the most antibodies. So whenever the reason it's important, so this is usually when we do the Rh negative, Rh positive in pregnancy to ensure that we are not giving somebody that's Rh, or if somebody's Rh negative, you can't give them, Rh positive blood. It can cause severe hemolytic disease of the fetal and newborn, specifically with the anti-D and anti-C. And then this can also cause hemolytic transfusion reactions, which is possible with the extravascular hemolysis. So whenever we discuss the O blood, whenever we give it uncross match, there's specific age and gender that we differentiate a little bit. So all male patients and female patients greater than 50 years old, they can receive Rh positive blood, as there's less concern for alloimmunization for future pregnancies. All females under 50 receive Rh blood if possible, again, to prevent this alloimmunization and hemolytic anemia of the fetus and newborn. If unable to provide this Rh negative blood, you can use RhoGAM to help prevent alloimmunization, only if given small amounts though. And if you're using large amounts of blood and still needing to protect for future pregnancies, you can potentially use exchange transfusion. However, of course, if you only have Rh positive blood and patient is hemodynamically unstable and you have to save their lives, you have to give them Rh positive, even if they're Rh negative. And another non-ABO antigens, there's the KIDS system, denoted by the JKA, JKB, and JK3. These are warm reacting IgGs. They can fix the complement with IgM components. These can cause severe hemolytic transfusion reactions. And there's a dosage effect depending on how the expression of these KID systems in somebody's genetics. And these can cause delayed hemolytic transfusion reactions or mild hemolytic disease of fetus and newborn. The MNS system, there's a glycophorin A and B. Glycophorin A is typically insignificant, carries M and N antigens. Glycophorin B, which carries S and U antigens, its IgG and can be significant. Now, Duffy system is definitely a more known one, I would say. It can cause IgG, severe hemolytic transfusion reactions that can usually be delayed in intravascular, which is different than most others that cause extravascular hemolysis. The KEL system, it's anti-K. It's the second most common non-ABO after the anti-D, which we discussed with the Rh status. These are IgG, and they can cause severe hemolytic transfusion reactions, which may be acute or delayed, and that's usually extravascular. It's pretty interesting, though, that this one, it damages the RBC precursors. So this ends up being more of like a suppressive versus hemolytic, as the others would typically cause extravascular or intravascular hemolysis. This one actually suppresses the formation of RBC. So in summary, there's limited supply of O blood, so the Rh negative blood and O negative blood. So you order uncross matched blood, as discussed before, patients that are hemodynamically unstable or actively hemorrhaging. Once the type has been performed, though, it's important to switch to O blood to the type that's specific to that patient, so that you avoid using this O blood negative or O negative blood or positive blood, since there's a limited supply. And then once cross-matched antigen studies have been performed, switch to that cross-matched blood that's even more specific to avoid these non-ABO antigens. And then treat the potential alloimmunization as necessary, as we discussed with Rh status previously. And here's some of my references. Thank you.
All right, I just want to make a few comments and then we're going to open up the questions. Real quick, I just want to make some clarifications about MTP. We've done a lot, nursing, ER, surgery, the transfusion committee have done a lot of different scenarios practicing MTP and training nursing. In nursing, the communicator will assign all those roles and everybody knows their roles. The physician's in there taking care of the patient and giving orders. So the physician never has any of those roles that were brought up. The one big thing I wanted to bring up today was we had an MTP, not last month, but I think the month before, and 8 units of SSP got wasted. And what happened was somebody was transfusing the packed red blood cells, but not using the SFP, and then getting the next ice chest. When a runner goes down to the blood bank, pick up the next ice chest, to pick up the ice chest, blood bank is making the next ice chest for that patient. So when the runner comes down, they may or may have the ice chest with them. It doesn't matter. Blood bank is going to release that next ice chest. So what happened was the runner went down, got an ice chest, the runner went down, got a second ice chest, the runner went down and got a third ice chest. So we know at least 3 ice chests were probably used, maybe 2. And if the FFP gets taken out of the ice chest and not used and gets past a certain temperature, or the blood product, the packed red blood cell, it's wasted and can't be used. So when you guys are doing an MTP, make sure you leave all the blood products in the ice chest until you're actually transfusing them in the patient. If they don't get used, they need to go back. Platelets are different. That's the other thing, platelets have been wasted because they don't get used, and then someone puts them in the ice chest. Then the platelets are no longer good as well. So packed red blood cells, FFP, have to be stored in the deal, and they have a temperature indicator on them that lets blood bank know if this is good or not good. So that's just some clarification about MTP and what all we have done, and we've come a long way on trying to build relationships with surgery, with the ER, with blood bank, and knowing, hey, when we activate the MTP, the first thing we do is we call it overhead now, just like we kind of call rapid response code blues, we call MTP in the room number, right? And just something for you guys to be aware of, MTPs are only done in surgery, ER, or the ICU. So if you may call a rapid response, and then you're moving that patient to the ICU, so you need to let the blood bank know what room is that patient going to the ICU. So by the time the runner's going down to get the blood, we get the patient moved down there, and it's all runs pretty smoothly. So we've really come a long ways with MTP here at the hospital. So that was kind of another thing I just wanted to bring up. So we're very fortunate to have Dr. Soto with us this morning, and y'all can be the lab manager, so we can, and then plus our speakers, more than happy to answer the questions. I'm gonna look here. Did anybody have any questions? Usually we have a lot. Maybe not. We look on. Here, we have any on Green.
I do have a more of a comment, maybe Dr. Soto can speak to it a little bit, but you know, we talk about alloimmunization a lot in pregnant patients and future pregnant patients. I think it's also important to, you know, remember that patients who potentially need a transplant later in life are really affected by alloimmunization. And so it's important to, you know, keep with your transfusion guidelines and make sure you're not transfusing unnecessarily. We see a lot of patients here that could be potential candidates for liver and or kidney transplant. And, you know, if they get unnecessary transfusions, that could really impact their eligibility to receive a donor later in life.
One thing I want to comment on what you were saying about MTPs and not using the plasma or the platelets. If you think about it physiologically, you're putting red blood cells back in your patient, you're putting more blood back in your patient, so you're actively helping them, you know, oxygenate their tissues. But the way coagulation works, you require a lot more than just red blood cells. If you don't have the platelets and the clotting factors, there's nothing for those red cells to kind of stick to. You're just gonna start bouncing around. But it's really the fibrinogen and the clotting factors that pull that platelet blood. The red blood cells are just keeping the tissues alive, but if you don't use the plasma and the platelets, you're not getting those pieces. That's why the use of proper trial you can explain that very well. So we get when you see that a lot of, you know, uncrossed matched units were used, but the plasma and platelets weren't used. I mean, I get a little worried, like this patient might bleed later on. So keep that in mind.
Thank you. Yeah, yeah, it's important. That's why it's, and that one platelet is equivalent to 4 or 6 of the other. So that's that 1-to-1 ratio that's so important. Are there any other comments or questions?
Yeah, within the MTP scenario, I guess my question is, when we're actively in MTP, if the physician were to say, hey, like, we're gonna give a unit of blood, but hold the FFP, and now we're outside of the 1-to-1, how much pushback should be there? Like, if we're in MTP and those micro decisions happen, I feel like that kind of cascades down to giving another unit of blood, holding FFP, and we're kind of in between holding MTP and then also, like, we're in between basically calling MTP off and then making decisions. So when that happens in phases of care, like ER to anesthesia, when we're giving blood, I don't feel like that always goes well for us, so.
And to speak to that a little bit, so that happens a lot of the time, even in the ICU, where we'll be asked like, what product do you want to give next? And so like, it doesn't have to be like 1 packed red cell, 1 FFP in the platelet, and then you do the same cycle. So as long as that 4-to-1 ratio is still met, then it's usually okay. But I think that happens more frequently than not, where the physician that went to do next, and so sometimes we'll do like 2 packed red cells and then move to FFP, and then, but as long as it's within that 4:1, that's equivalent to that 1:1 ratio. I don't know if that answered your.
But I think you're also saying, what if it changes, now it's no longer really becoming an MTP and they have a specific thing that they want? And we probably should cancel the MTP unless this patient still, if the patient's actively hemorrhaging, you need to do the 1:1 ratio, and he's right. So sometimes we have rapid transfusers, guys, so this blood's going in fast. The other big thing to bring up is large bore, right? So in surgery, when they put in, this is why a cordis gets put in, right? In the ER, the big question on boards is you two 18 gauges, right? You gotta have large bore to drop that blood in quickly. So we'll have 2 rapid transfusers at the MTP. You can give 2 packed red blood cells, 2 FFP in the other one. And if you have 2 sites, you can be pumping both of those in at the same time if you need to. But it's true, you can give, as long as you're using up that ice chest before grabbing stuff out of the other ice chest, if you see that happening, then there may need to be some education, and maybe in that moment, it might be hard, but that's something you can come to the transfusion committee and ask for some assistance and say, hey, this happened, and.
Yeah, I don't think it's like a count within the OR, because we lay, I mean, personally, I lay a big blanket out and I set them and I can visually see them as I'm counting, because especially in an MTP scenario, and I know we've talked about it, sometimes blood being released in an MTP scenario is not chartable for us. And because it's not chartable, other than making a quick note, which requires me to look at the blood and type, and I don't have time to do that. I'm essentially the documenter, the communicator, and 2 nurses, because I run 2 Belmonts at the same time. So like, that's the way that I do it. I don't know what I mean, that's what most attendings do, so we can visually see the 1:1 while we're doing it. So anyway, it's just a matter of, I think if we're in MTP, making sure that when the patient gets to us, we understand where we're at in that 1:1, because we've been very, like, not just a few units. Right, so.
Yeah, and I think you make sure you use all the products in that one ice chest before grabbing products out of the next ice chest.
Yeah.
And knowing, so the nurses don't, in an MTP, the nurses are not charting every unit during the MTP.
Yeah.
They're keeping, there's a sheet that has stickers. Do you put it on the sheet? Do you all have that sheet?
So that's the thing, is like, the nurse that we have in the room is available to surgery and to us, and so that nurse is also splitting a lot of duties. So we
Right.
don't put MTP protocol in them, it's more in our wheelhouse of getting that stuff started.
Do you
So,
take a sticker off the pack of your
Yeah.
blood cell?
but that happens at the end, because.
That's fine, yeah.
So.
That's fine.
Yeah, we do it at the end.
Okay.
It's easier, but.
Yeah, just you keep all the bags there, and then and then there's that sheet, if you put them on those sheets and send it down to blood bank, that would be great at the end.
Yeah.
Any comments now for me about that?
I think the only, also sort of used a really good way to describe MTP and uncross-matched blood that I like using whenever I teach nursing. And for uncross-matched blood, we say, do you want just the burger or do you want the value? So in one of the presentations, you talked about how long does it take to cross-match something? And if you're doing a typing screen and a cross-match, it's going to take 30 to 45 minutes. But if your patient is in the ICU and they already have a typing screen down there, then it's just gonna take us a quick 5 minutes to cross-match that blood. So you don't necessarily need to ask for uncross-matched blood there. If, however, your patient is in the ER, then we don't have a typing screen yet, and the patient needs blood immediately, and they only need a couple of units, then we say just a burger, then you would order uncross-matched blood. And you would get a quick 1 or 2 uncross-matched units. If that patient has a massive GI bleed and you're gonna need blood and plasma and platelets and possibly cryo, then you need the value. That's when you need everything. And then one more point on that MTP, if you get to that third floor where you need cryoprecipitate, then cryoprecipitate, if you don't use it, it also stays at room temperature and you don't have to put that one back in.
Correct. Did y'all hear everything she said? Never get that? Okay. Because I think that's kind of important too. So when you call an MTP and the patient's already in the hospital and they've been typed, remember, type and cross and then type and screen is different than type and cross. Type and cross, they're preparing blood. type and screen, it kind of takes care of that 30-minute process, so it again takes 5, 10, 15 minutes. But if you're calling it MTP, that first ice chest that comes up will likely have uncross-matched blood in it, because they may be, you know, and then the next box will have some, or it may have 2 uncross-matched, I guess, and 2 cross, and if that's the case, maybe give the cross match first. You see what I'm saying? And then by that time, you may be able to get, I sent uncross matched blood back to blood bank before during an MTP. That's one time where I've actually sent blood back because they went and got the second ice chest and I didn't need to give the uncross match, so I kind of preserved it. Other questions or comments? Because we have a lot of different people here. Surgery, anesthesia, ER, IM. Family medicine, I think, yeah.
I'll say documentation is very, kind of touched on it. Documentation is really important, so we don't get to be present when you guys are doing handoffs and which units are being transfused, but we talked a little bit about that at committee. Is some of these units go into the ether, we don't know if they're getting transfused or not. So if we can have some way of documenting that they're getting transfused. I know you guys do a really good job of checking everywhere to see if they're getting transfused, because for us, it's an FDA regulated product. And there have been times we have no idea if they're transfused or not. It's kind of a problem for us as far as regulations go. Tracking your patients later on, we may find out that, you know, X that was transfused during MTP, a patient that previously said they didn't have such thing later on, they did have to backtrack a lot, but we don't know if they're transfused or not. We can't do the detective work with the FDA.
So in the past, in the documentation area for the OR and the anesthesia set, we have been unable to manually or scan uncross matched blood products in. And so I talked to and he's going to talk to biomed. So I think that's been an issue. What we've done is just end up keeping the blood packages and then putting them back in the cooler in that scenario, because usually there's a lot going on. Really time consuming to do it quickly. So hopefully that'll improve our. It's been a pretty big problem.
Yeah. Okay, let's see if we can, let us know if you're not, if you don't get an answer, so we can take that further, okay? And make sure we take care of that. It's great. Anything else? If not, I appreciate you guys' time and attention. Thank you.